Hello, everyone, and welcome to today's live broadcast, Pneumonia, Diagnosis, Bacterial Superinfection in COVID-19 Patients. I am Alexis Krause of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by OpGen, a precision medicine company harnessing the power of molecular diagnostics and bioinformatics to help combat life-threatening infectious diseases and fight antimicrobial resistance to improve patient care. For more information about our sponsor, please visit their website at opgen.com. So let's get started. I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click on the Send button. If you have trouble seeing or hearing the presentation, report your problem by clicking on the Ask a Question box located on the far left of your screen. I'd like to now introduce our presenters, Dr. Christian Jeske, Professor, Head of Division of Clinical Microbiology and Immunology, Department of Laboratory Medicine, Karolinska Institute at Stockholm, Sweden, and Dr. Drew Bell, Medical and Public Health Microbiology Fellow, Indiana University School of Medicine, Department of Pathology and Laboratory Medicine in Indianapolis, Indiana. For a complete biography on our presenters, please visit the Biography tab at the right side of your screen. Dr. Jeske, you may now begin your presentation. Welcome, sir.
So thank you very much for the introduction. The title of my talk is Diagnosing Bacterial Pneumonia in COVID-19. The scope of today's presentation is to give you an overview of state-of-the-art diagnosis of bacterial pneumonia and also to describe complexities and challenges of pneumonia diagnosis in COVID-19 patients. I would also like to discuss with you potential clinical consequences of lack of diagnostics and to give you some examples from a study at Karolinska on COVID-19 patients with hospital-acquired pneumonia, comparing diagnostic outcomes with Unyvero LRT panel and quantitative cultures. Finally, I would like to give you some examples of clinical utility in selected patients according to medical chart review. Following the second, you have established that you assume the clinical syndrome to be pneumonia. The second part of making a diagnosis is selecting the correct sample material. And in the following slides, we will discuss that and discuss what the options are for lower respiratory tract sampling. One sampling type which is very accessible is the sputum sample. The problem of this sample is that it's always contaminated with the oral microbiome. It's also very clear that qualitative cultures have limited diagnostic value, and it's absolutely necessary to assess the specimen quality, which should be low in epithelial cells and high in neutrophils. Also noteworthy, in many patients, it's helpful to do nebulized sodium chloride to induce coughing, and that can also be done with the assistance of a physical therapist. If you conduct sputum wash, you can remove a large part of the oral microbiome, but that's usually not a standard practice everywhere. If you have good quality sputum and growth of a significant amount, which is defined as more than 10 to the 5 CFU per ml, the sensitivity has in various investigations been found to be around 60 to 80% and specificity around 90%. So it can be a fairly good test, but noteworthy. For instance, for the clinical syndrome we are discussing with COVID-19, many of these patients are unable to produce sputum even when they are exposed to induction. This leads us to a need for invasive sampling in these patients usually to get the lower respiratory tract sample, and one of the key tools we have there is the protected specimen brush, or PSB, which is a brush which is millimeter sized. on the edge of a metal wire, protected by a plastic catheter and sealed by a plug. And following the sampling, the catheter is cut off and the brush is sent in 1 milliliter nutrient broth. It is a test with a good sensitivity and specificity according to a meta-analysis. What can also be said about the brush is that it can be taken either through bronchoscope, but also through a tube in ventilated patients, which is not as good since you cannot see exactly where you are in the respiratory tract, but it still is a very helpful test where you can get the sample more efficiently also in a patient who is ventilated. We also have an option of doing different forms of lavage. The classical bronchoalveolar lavage, or BAL sample, is done with 100 to 150 sodium chloride, which is injected, and then you conduct aspiration of around 100 mL. This is also common in ICUs to do so-called low volume BAL, which is done with around 1/10 of the volume and also with a much lower yield. The overall performance is a sensitivity of 73 and specificity of 82%, with a cutoff of 10 to the 4 CFU per ml. According to most of these references are from almost 20 years back, but they are quite good, robust investigations. One final sample which can also be taken invasively is the endotracheal aspirate, or ETA, which has a low specificity if it's only done qualitative manner, but if it's done quantitatively, it's a fairly good test. The standardization is a key challenge with this sample type, since frequently people will use it in many different forms. And it has very good performance, both in terms of sensitivity and specificity compared to other samples like, for instance, PSP, if you use a cutoff of 10 to the 5 CFU per ml. In summary, if you do quantitative cultures, these are the interpretation criteria that would be evident from several different investigations, and are, I would say, to a large extent, internationally well accepted cutoffs, where you have for BAL and low volume BAL somewhere around 10 to the 3 to 10 to the 4. For PSP, it's 10 to the 3, and ETA and sputum 10 to the 5 and 6. And you can also have a cutoff for possible significance if you want a buffer category to ensure that you are not dismissing too many findings. In terms of the general guidelines, these are some examples of the Swedish guidelines for sampling in lower respiratory tract. There is quite some interest in doing lower respiratory tract sampling in Sweden, perhaps more so than at least in some other European neighbor countries. And in hospital-acquired pneumonia, excluding VAP, and in VAP, it's quite common to look at the same set of samples. So lower respiratory culture is always recommended, along with blood culture and urinary antigen, and then to varying degrees looking for also atypical pathogens. And even non-tuberculous mycobacteria and nocardia are more common, obviously, to look for in immunosuppressed patients. And then viruses, well, those are looked for in all samples these days, but prior to COVID, it was common not to routinely look for it in HAP and VAP. And honestly, all of the patients we are talking about here already are diagnosed with COVID, so it's also not necessary to conduct PCR for COVID if they develop a HAP, which they usually do after some initial time in hospital. So some of the limitations of the quantifications is that for some bacteria, it's not really considered relevant to consider that you have some kind of colonization or safe level. Another important aspect is that treatment before sampling can affect the quantification and can obviously also lead to false negative results. Sampling early in the course of infection can give you results below the cutoff, and there is also problems of reproducibility. In many investigations, this has been shown that it can differ with one dilution step when taking multiple samples with the same technique, and even the concentration can vary with different sampling sites in one lung segment, and that lack of reproducibility is a bit inflated even when you look at samples that are taken to the tube in ventilated patients. One can also question if it's important to conduct invasive sampling, and there is limited support in one Cochrane analysis that sampling is improving mortality, but there is definitely support that sampling is decreasing the overall antimicrobial exposure. And in fact, for the COVID patients, invasive sampling is in many ways the only way of getting good samples from the lower respiratory tract. I would also say that many of the old studies showing that sampling is not improving mortality are also done in times with lower frequency of AMR and might want to be repeated. So when you do Cochrane analysis with old studies, that can sometimes be a caveat. Obviously, sampling should not delay therapy, but if it has been done according to standards, it can definitely guide decisions on therapy. And there are different practices in different countries, with some that are more positive to conduct invasive sampling to promote good antimicrobial stewardship. And importantly, lack of sampling leads to lack of data to modify guidelines over time. I can add that at Karolinska initially there was some uncertainty with ICU physicians who feared that there would be a greater risk of transmitting COVID if they did sampling. So initially they were a bit careful, but quite early on we were able to convince that this was still very important, that we got these samples when patients developed hospital-acquired pneumonia. So in discussion further about the etiology of hospital-acquired pneumonia, it's quite clear, first of all, that there are some findings which are sometimes reported in studies, but should, at least in my opinion, be questioned. Those are, for instance, enterococci, coagulase-negative staphylococci, and also Candida species. There is also a couple of bacteria that are largely considered to belong to the respiratory microbiota, such as the Streptococcus mitis group, of which Pneumococcus is also one of the members. Streptococcus pseudopneumonia is one of it's being discussed sometimes as a pathogen, but it's still uncertain. Haemophilus parainfluenzae, there is some not always agreement on whether that should be considered or not, and there are even some other corynebacteria like Pseudodiphtheriticum, which is sometimes considered a pathogen, at least in immunosuppressed patients, but sometimes also as respiratory microbiota. I would like to raise a word of caution for some studies that finding a microbe in a patient with a clinical syndrome does not necessarily mean that this is a causative pathogen of that syndrome. And in fact, many COVID patients presented early on with a clinical picture resembling community-acquired bacterial pneumonia, but there were no findings of bacteria in their lungs at that stage. And it just tells you that although the picture looks like bacterial pneumonia and you find something which I've described to be a potential colonizer, that doesn't make that bug the causative pathogen. And this is just a reminder about Koch's postulates, where there is actually also a part where you should try the microorganism in an animal model to see that it actually causes that kind of clinical picture. To give you an idea of the panorama of disease in Sweden, where the study I'm going to be describing later was conducted, this is some insight into the etiology of ventilator-associated pneumonia in South Sweden and at Karolinska, and we see more or less the expected pathogens, with Staph aureus being quite common, Haemophilus influenzae, and also to varying degrees we can see different gram-negatives and sometimes a bit more rare findings as well. In different international literature, this is a review, a French review of several papers that have and healthcare-associated pneumonia, and we can see that overall Enterobacterialis, or Enterobacteriaceae as it was called then, is around 1/3, non-fermenters around 1/3, and gram-positive cocci around 1/3. That is the overall picture when looking at these studies. There is also quite limited differences between healthcare-associated pneumonia, hospital-acquired pneumonia, and ventilator-associated pneumonia. Normally, we have most diagnostics for ventilator-associated pneumonia, so that's where we have most of the etiologies from, since those patients are more likely to be sampled invasively than many other categories of patients. Another important factor to consider is also the risk factor for resistant pathogens, and for this particular situation, prior intravenous antibiotic use is a big risk factor for MDR, ventilator-associated pneumonia. There are also other things like septic shock at the time of VAP, ARDS, and 5 or more days of hospitalization prior to occurrence of VAP, and even acute renal replacement. And then there are the overall risk factors for specific bacteria, and it's quite frequently linked to previous antibiotic use, which was given in many of the COVID patients, notably. When we look at healthcare-associated pneumonia in COVID-19 patients, this is a meta-analysis of 30 studies with almost 4,000 patients, and we can see that the pooled proportion with laboratory-confirmed bacterial co-infections was around 7%, and in ICU patients only, it was around 14%. And in that same study, when they looked at bacterial pathogens, what is a bit surprising in this finding is that Mycoplasma pneumonia was very common. Other than that, we are finding the expected pathogens that we normally see in patients with healthcare-associated pneumonia. So the reason why Mycoplasma was very common here is a bit more difficult to understand, but that has not been seen in our material, for instance, and we would also not report Enterococcus faecium as a pathogen. There are some studies comparing culture and the impact of molecular diagnostics in critical illness, which were done earlier during 2021 and also 2020. So these are two published papers that have looked into respiratory samples from ICU patients and found good sensitivities and specificities of molecular tests in this particular case, and also with the molecular tests driving antibiotic changes. And on the other side, the study in critical care 2020, where antibiotic modifications were also done, and illustrating the possibility of doing de-escalation, and also again reiterating that Staph aureus, Haemophilus influenza, and even Moraxella catarrhalis were leading pathogens detected. Now let's move to the material from Karolinska. This is a very recent publication in which we applied the Unyvero hospital-acquired pneumonia panel on 83 samples from 68 subjects tested using the HPN application. 55 samples were from the same number of unique subjects, and then we had multiple samples from a subset of the patients. The mean age of our patients was slightly below 60, and 74% of the samples were from males, and quantitative culture was used as a reference in this investigation. The Unyvero panel looks briefly like outlined here, covering all of the pathogens we have recently looked at in previous slides, and also atypical ones like Legionella and Mycoplasma, for instance. It covers also pneumocystis, for instance, and definitely also some of the early hospital-acquired pneumonia pathogens that are more resembling what you find in community infections. There is also a broad array of antibiotic resistance markers, quite comprehensive panel for the most common carbapenemases, both in Enterobacterales and in Acinetobacter. There is also the CTXM for Enterobacterales encoding cephalosporin resistance, and then some other resistance genes where maybe the most important is that for methicillin-resistant Staph aureus, there is both MEC-A and MEC-C. Looking more into the results on this investigation, this is the panel of our findings. So Staph aureus was the most common with 23, which were regarded true positives, and also 8 that could be seen as false positives, at least if you go by culture to be an absolute reference, and to say that culture negativity means that it should be regarded as a false positive. But we will discuss that a little bit. We can also see in a decreasing number of occurrence here that E. coli was fairly common also and was not missed by culture in any of them. The overall sensitivity was 95% and specificity of 98%, with the positive predictive value of around 72, and a negative predictive value, which is also very important, almost at 100%. If we look further into the results, we can here study the number of samples with concordant results and discordant results. So that could be either standard of care positive and the HPN positive, or standard of care negative and HPN negative. And then we can see for the discordant results that we had a few cases where we found negative with HPN and positive for standard of care, or there were the other way around where we had standard of care which was negative and HPN positive, and then sometimes they were not exactly identifying the same microorganisms, but those were very few occasions. So here one tracheal secretion which grew Klebsiella aerogenes and was negative by HPN, and then there was one which had Klebsiella aerogenes and had Staph aureus by HPN, and there was one BAL sample that grew Staph aureus and Klebsiella oxytoca, and for HPN we found only Staph aureus, but mostly we found more pathogens with the HPN applications than we did with culture, and that comes back to the definition, and sometimes when you are investigating and comparing to standard which is less sensitive, that might lead to some confusion on what you should actually call false positive. I will show you some examples of that. So this is also some overview of the additional microorganisms detected with Unyvero. In 8 cases, Staph aureus. In 4 cases, Serratia. In 4 cases, Pseudomonas. 2 cases of Haemophilus influenzae. 2 cases of Klebsiella oxytoca, and 1 case of Stenotrophomonas maltophilia, which is also included in the panel and is obviously important to detect because it is intrinsically resistant against so many of the regular treatment alternatives. So this is an overview of the first study that we conducted with a head-to-head comparison between the HPN application and culture. And if we look more into the subset of patients where we did chart reviews and had repeated samples, we could overall group them in one group where standard of care and the HPN was 100% concordant. And then we had another group where the HPN pathogen was confirmed later by standard of care in subsequent samples. This group of patients were, as a consequence of lack of finding any microbial etiology, they were exposed to longer periods of empirical treatment, which could obviously have potential disadvantages, such as either no coverage of the pathogen, or in case it's too broad for too long, microbiome damage, which can also lead to other problems, such as C. difficile infections, but even in general being highly disadvantageous, as has been shown in many studies highlighting the importance of the microbiome. We can also see here that the hospital length of stay was longer in group 2, and the ICU stay was longer, and the VAP duration was longer. We do not know if that could have been shorter had we had targeted therapy earlier, but that is at least one possibility that we can draw that potential conclusion from the data set. So if we look more into Unyvero's potential impact, more specifically, this is where we could look at the timeline where the Unyvero result could have been available on the same day. Now it was run in batches at the end of things, so the results were not available to the clinician at the time of clinical management. But we see here in group 1 and group 2 that there is quite some difference in how many days are elapsing before the culture result is available. And in group 1, there is the possibility of having pathogens not covered by empiric therapy due to, for instance, intrinsic resistance or multi-drug resistant organisms. And that could be done significantly faster with a molecular test like Unyvero. And in group 2, where we even had a negative culture after several days, we can say that the impact could be even greater of having the molecular tests. And we will look at some specific cases at the end of this to illustrate this maybe a bit better. The first patient case, a 59-year-old female, where we had a tracheal aspirate, which was the most common sample type we had. This was a lady with asthma, diabetes mellitus, and obesity. And the date of COVID positivity was the 19th of April. And then she was put on ventilation on the 22nd of April, and that continued until the 15th of June. So you see 55 days. And this is the thing with the COVID patients, that they are sometimes really ventilated for extremely long periods, and particularly this was true at the beginning before we knew exactly how to treat these patients optimally. Unfortunately, there was a fatal outcome for this specific patient. What we can see is that for the first sampling, which was done on the 20th of May, there was Pseudomonas detected, which was resistant to the treatment which had been given prior to sampling, and the HPN application found the same thing. Whereas on the 30th of May, the patient was started on ceftolozane, tazo, and colistin prior to sampling, and we can clearly see illustrated here that the quantitative culture becomes then false negative, whereas the HPN application is positive, and that is corroborated by the fact that we could later on recover Pseudomonas in the culture from 8th of June. So that essentially tells the property that this test has to correctly identify pathogens in those that have been previously exposed to antimicrobials. In case number 2, 51-year-old male, this is a BAL sample. The first date of COVID positivity was 15th of April 2020, and the patient was ventilated for 53 days and was later on discharged to rehab. And we can see here that initially the patient had antimicrobials prior to sample, and the quantitative culture showed yeast, whereas the HPN application showed Staph aureus. And then later on, Staph aureus could be detected also by quantitative culture, suggesting that it was most probably false negative some 1 week earlier when it had been taken under antimicrobial pressure. So this is another example of the potential utility. And finally, there is also a third case with a 40-year-old male, also with several comorbidities, ventilated for 4 to 6 days. And in this case, we found initially a concordant result with quantitative culture and HPN. And then on cefotaxime therapy, culture showed only Serratia, whereas the HPN showed Serratia and Staph aureus. And Staph aureus was evident later in quantitative culture, which again suggests that these additional findings are probably true findings and not false positives. Finally, there is also some evidence that Unyvero system, this is not from our own investigation, but from a poster that has been shown previously with comparison of culture versus Unyvero on prospective BAL samples, also a chart review, and with 4 culture negative Acinetobacters that subsequently grew Acinetobacter in culture. And in this case, the modification of treatment was too late and all the patients died. I would then, in summary, like to emphasize that distinguishing those patients with bacterial superinfections early and accurately is highly important for patient management and antibiotic stewardship. Also, that Unyvero demonstrated high diagnostic yield, higher than culture, enabling a more rapid diagnosis in hospitalized COVID patients, or at least would have done had the result been available. An excellent negative predictive value, a strongly reduced diagnostic turnaround time, and also that many that were culture negative initially were positive in subsequent cultures. And as a conclusion, Unyvero could provide clinicians with earlier data to inform antimicrobial decisions. And with that, I would like to thank you for your attention, and I would like to leave the word to Dr. Bell for the second talk. Thank you very much.
Okay, thank you, Dr. Jiska. Get control here. All right, so I'm Drew Bell. I'm the microfellow at IU, as was mentioned earlier. As part of my fellowship, I've gotten involved in our group's industry-sponsored research group. And today I'm going to talk to you a little bit about a study that we performed in conjunction with OpGen, testing out the Unyvero, seeing how it performed in some subsets of our patients. After we kind of talk about the study, I'll go through some specific cases as well that I think exemplify the characteristics of molecular testing in this type of diagnostic algorithm. So we've talked a little bit about pneumonia, of course. There's serious clinical implications when it comes to pneumonia. It's relatively common. It kind of plagues our hospital systems. And it comes with significant costs. Increased length of hospital stay are going to increase, of course, the chances for patients that have adverse outcomes, and also the amount of money that it takes and the capacity of the hospital. We're also going to see changes or significant contributions to mortality. When you look at hospital-acquired and ventilator-associated pneumonia together, they're a very common form of hospital-acquired infections. We're very concerned about controlling them in our hospital system. And of course, with these infections, we're really worried about resistance. Either they're picking up the organism from the hospital itself, where we're going to see more resistant pathogens. But then also within the treatment of each patient, we have to be sure that we're using our antimicrobials wisely. And we don't want to accidentally begin to develop antimicrobial resistance. Of course, on the right here, we have some of the pathogens we've talked about as more of our common acute pneumonia causers in hospitalized patients. And of course, many of these are associated with some particular mechanisms of resistance. So we're really concerned about the types of antimicrobials that we're using in these patients. So kind of key to our therapy is an etiologic diagnosis. So conventionally, these etiologic diagnoses of pneumonia are going to rely on more microscopic observations, looking at a gram stain, seeing if we see any bacteria or not, and then following up with culture. The sensitivity isn't great for these types of tests, and it does take a significant amount of time. If you're waiting for culture, you're waiting at least 16 to 24 hours before you actually have the organism there. Therefore, your traditional therapies are going to be empiric. You're kind of starting a broad antibiotic therapy while you're figuring out what pathogens are present and how could you possibly narrow that therapy, or making sure that you're including drugs to cover resistance you might see. So really these timely escalations and de-escalations are going to need some input from the lab. We're going to need some laboratory information. The figure here is from a study that was kind of looking at the importance of appropriate initial therapy in the patient's clinical course. Of course, this is in community-acquired pneumonia. And really what we see is that if you have appropriate initial therapy, your hospital stays are lower, and your readmission rate is also lower. Interestingly, this particular study did not find that there was a difference in mortality, but you're decreasing the amount of time spent in the hospital, and you're preventing those patients from coming back, which is always a good thing. So when kind of thinking of these conventional conditions, there are some strengths that molecular culture or molecular diagnostics can provide. So we can reduce that time to appropriate therapy if we can figure out the organism, or if we can figure out the resistance pattern earlier on. This is not only good to get the patients out of the hospital, but if you have antibiotic stewardship initiatives in place, it's going to help you be more judicious with your prescriptions. And then, of course, the resistance that we talked about. We'll talk a little bit about pneumocystis pneumonia in a moment, but that type of diagnosis is fairly insensitive, actually. And so this provides a notable improvement to that as well. There are also some challenges when it comes to molecular diagnosis, more just sort of cultural adjustments on how we interpret this type of data. So it's going to be much more sensitive. Very, very tiny amounts of DNA could be amplified. Now, this is mostly a good thing in the sense that we'll know all the pathogens that are there, or perhaps something being treated. If the patient has already started therapy, you might still find out if that organism is present or not. So we just have to know that we're going to be able to see things a lot clearer. At the same time, we have to keep in mind that ordering these tests, we have to think about the costs associated with them. So there are a few costs that we think about on the laboratory side. One, of course, is the cost of the test itself. So molecular diagnostic panels can be kind of expensive. And so we have to keep in mind that if we don't need the broad panel, then we should stick to focused diagnostics. But there are times when we don't really know, and we have to think about different pathogens, and that's where the panel has a place. We also have to think about the cost of the instruments and implementing these instruments themselves. For us, that really means that we want to find a platform that kind of meets our needs as a laboratory. So do we have the organisms that we're most concerned about? Can we use this as a replacement, or maybe not a replacement, but an adjunct to culture for particular complicated organisms, which we'll mention. And then we also want to keep in mind that although it kind of gives a preview of resistance, looking for the presence of markers or not, really we have to keep in mind that we only have a good basis for escalation in the sense that if we see a resistant marker, we can have a good idea if it's resistant. But if we don't see the resistance marker, we have to be cautious about how we de-escalate, because susceptibility can still go away in a sense with the phenotypic testing. So we've talked about it briefly before, but we'll touch on it again. So the technology we're looking at is the Unyvero LRT BAL. This is for our viewers across the pond. This is equivalent to the HPN panel used in the previous talk. One of the reasons that our lab was interested in testing this out is it does include some sort of fastidious or difficult to culture or completely unculturable organisms. So you have your mycoplasma, your chlamydia, your legionella, and your pneumocystis. And of course, the small amount of hands-on time is a big benefit too. So just so we're on the same page about PJP, or pneumocystis jirovecii pneumonia, this is one of the non-culturable fungi. It is fairly prevalent in immunocompromised patients, especially HIV-infected patients, or who we think of the most, but also anybody else who has immune suppression. We see somewhat different courses in folks with HIV than with those who do not have HIV, and so that will kind of change. Our understanding of HIV-negative pneumocystis will probably change as we gain more molecular information. We also want to be cautious of the treatment for PJP, in that trimethoprim sulfamethoxazole, or Bacterial or SXT, is associated with some adverse effects. So we really want to be careful with this drug. We should note that there is some amount of colonization that can occur in the population. So we're really just starting to learn about this as we employ molecular technologies. So there is some colonization in immunocompetent individuals, and we're starting to think that maybe this organism is playing a role in some conditions that were previously ignored because they were unable to be identified microscopically. So in immunocompetent individuals, the burden is usually a bit lower. And in that sense, we might be able to detect more with molecular technology. We see some co-infection, of course, in the high-risk populations. And you'll notice that some of the risk factors for pneumocystis colonization really overlap with the risk factors for pneumocystis pneumonia themselves. So sometimes colonization is thought maybe more of a threshold that we cross than anything else. When we're conventionally diagnosing PJP, what we're really looking at is the trophic or cystic forms that we see in microscopic examination. Carrying out these stains and looking at them under the scope is kind of a pain, and the sensitivity just isn't great, especially when burdens are low, as they are in immunocompetent individuals. And there's lots of great evidence, of course, that real-time PCR is good for detection and is especially good for ruling out pneumocystis. The negative predictive value is extraordinarily high. So in this particular study, we wanted to compare our standard of care identification scheme. So that's mostly, we're just going to be talking about bacteria and then, of course, pneumocystis here. And then we wanted to compare them with the molecular technology that the Unyvero provides. So really what we're seeing is that we're going to collect a BAL. Usually we can get an ID in between 16 and 24 hours, but it could be longer if it's a triggy organism or a slow grower. And then at the very earliest, we can get susceptibility testing at 24 hours. These base numbers here are if everything goes right on our standard of care and everything lines up with when we can carry out those tests and everything is behaving. Not always the case, but they're good starting numbers. And of course, for patients with concern with PJP, we really are going to be looking microscopically. So this was a number of stains, including some that aren't exactly relevant to PJP diagnosis. But we're getting, generally, can we see anything? Okay, including in the study, we had 63 individuals, mostly male, in a fairly wide age range, although they tended to be older. We had a nice mix of community-acquired, hospital-acquired, and ventilator-associated pneumonia, and then a few patients with no pneumonia whatsoever. Also included in this number are 9 patients that were determined to have pneumocystis pneumonia by our standard of care diagnostic algorithm. So when we compared our Unyvero results to our standard of care, we saw pretty good agreement. But I should mention the types of disagreement that we could see, just so we're all on the same page here. Really, when you compare two methods, your new method can either add a new organism or it can forget an organism, it can omit one. When it comes to our cutoffs here, I kind of categorize them into 2 bins, being either minor additions or minor omissions, and then major additions and major omissions here. The way that we quantify our cultures is important. So, if we see 1,000 colonies, that may only be, 1,000 CFU per ml, that may only be actually 1 colony on a plate. So not many colonies whatsoever. We also quantify by quadrant of growth, so being 1 plus, 2 plus, 3 plus, 1 plus being very relatively little growth here. So when we did make this comparison, though, we did see a large amount of complete agreement, about 75%, which is pretty good and kind of in line with what other studies have seen as well. We also saw a few cases where there were some minor omissions and minor additions, and then some major omissions and major additions. We'll talk about a few of these cases, the major cases, and there may be more to them than just do they agree or do they not agree. In fact, because of the increased performance of molecular assays. We also looked at the treatments that these patients received, so kind of discounting the molecular data for a second. And this is what we would have done with those patients had we had perfect diagnostic technology and could see the future. And what we saw is a lot of patients were undertreated. And a significant amount were overtreated, and some were just fine. Only about a quarter were on the right treatment to begin with. And then, of course, some of these, especially the patients without pneumonia at all, were considered to be appropriate without any treatment whatsoever. And so when we kind of factored in our Unyvero results here, we saw that we could change the way that some of these therapies would have gone. So about 40% of cases, the results would have prompted either an escalation or a de-escalation of therapy. There, again, were some where the treatment was not needed at all, so we would not factor in that analysis here. When we talk about not enough information, about a third of these cases, it was either not enough information that we could find in the chart, or there was just not enough new information provided by the Unyvero in the sense that it kind of supported the current therapy as well. But a good amount of escalation. So when we think about those patients who are being undertreated, this provided good evidence to put them on maybe some stronger drugs or more targeted drugs. Okay, so we'll go through some cases and then we'll wrap up and have time for questions. So this first case we have is a 50-year-old guy who had a history of acute myeloid leukemia and received a stem cell transplant for that. And he comes in with a fever, a cough, and some shortness of breath. He had influenza infection recently and had been kind of in and out of hospital for treatment for that. And they were giving him Tamiflu, moxifloxacin as a prophylactic. His symptoms weren't improving. And when the patient came back in, they placed him on vancomycin and cefepime. But after a week, they discontinued this vancomycin as BALs and cultures repeatedly showed only influenza. So they thought they were clear of the bacterial woods. In this particular case, our standard of care culture identified Staph aureus. and at about 16 hours, and then only a scan 8 hours later, identified that there was methicillin resistance. At this point, about a day after stopping the therapy, they restarted back on vancomycin. This is one of those cases where the Unyvero would have come up with a bit faster of an answer. So it detected the Staph aureus early at its 5-hour time point, but it also had the MEK-A marker there. So we could know that the vancomycin therapy would have been appropriate at this 5-hour mark. So this would have been a good 11 to 18 hours earlier than with our conventional diagnostics. This is a good example. Why I chose to include it was that really this is why we like molecular technologies. They provide a prompt basis for escalation. This is also a case where the standard of care was performing very well in the sense that everything was done within that 24-hour period. It can take much longer to get these final reports. But this one we had early identification on the standard of care side as well. But it would have been much earlier if we had our molecular technology in place. The second case, we have an older woman coming in. She has a history of COPD, chronic kidney disease, some tobacco abuse, and she has shortness of breath, cough, wheezing, weakness, and is feeling kind of strange. When they did a CT, they noticed that there was a right cavitary lesion, and for which they wanted to get some fluid, and so they sent BAL in for culture. While they're waiting for the results, they started this patient on pip/tazo and azithromycin. So in this case, we detected M. cataralis at about 24 hours. So still pretty good as far as our identification pipeline. And then we confirmed that it was pan-susceptible at 48 hours the following day. So following identification, we reduced the treatment just to pip/tazo here, which we'll talk about in a second how we feel about that. So here the Unyvero would have also identified the Moraxella cataralis. Wouldn't have had any resistance markers at about 5 hours. So we would have gotten an earlier answer here. So really, when we think about how we treat this, talking to our infectious disease pharmacy team, they thought that this was a bit overkill. And although we were able to drop the azithromycin and just go with the pip/tazo, they felt that we could have gone even further and perhaps reduced this to something like amoxiclav. So this is a case where this type of information can inform antibiotic stewardship initiatives and maybe help de-escalate when possible. So we think of this as giving early basis for us to de-escalate therapy. Fortunately, in this particular case, there was never another pathogenic organism recovered, but the patient continued to have chronic hypoxic and hypercarbic respiratory failure, and the kidney disease became worse. And was eventually discharged to hospice. So this third case is a younger guy. He has no significant medical history, coming in with some dry cough, shortness of breath, and some subjective fever and chills. They found he had low 2 sats. They took a CT of his lungs, where they saw ground glass opacities. They also noticed oral thrush on physical exam, which they started treating with fluconazole and kind of made the physicians in this case worry about HIV, although the patient denied any risk factors. So despite a nice broad antibiotic coverage, the patient did not get better. So when they did do the standard of care BAL culture and microscopic analysis, they noticed that there was pneumocystis. And this occurred really quickly at about 6.5 hours after collection. And right about the time that this pneumocystis result came back, the antibody results also came back positive. So this patient was started immediately on Bacterial in about 6.5 hours. So this is kind of a classic diagnosis of when things go right for pneumocystis diagnostics. In this case, the Unyvero would have been a little bit faster than this at about 5 hours. Kind of the main benefit that we see in this particular case is getting all those slides and reading them requires advanced technical skills. It also is a significant amount of labor. The Unyvero is pretty straightforward and only requires a couple minutes to set things up. And so we kind of see it as expanding the ability to perform this type of testing without necessarily having the expertise or the extra hands-on time. In case 4, there's a little bit of a challenge case for the Unyvero here. We have a 43-year-old woman comes with fatigue, weight loss, anorexia over 4 months. Recently having shortness of breath and some other respiratory symptoms. The CT demonstrated a mass-like opacity with multiple nodules and ground glass opacities. And they were concerned about HIV based off of a couple risk behaviors. And it came back with a very low, of course, it came back positive, and the CD4 count was very low. So immediately they're looking at the BAL to see if they can come up with an agent for some of these respiratory symptoms. So our standard of care procedure only identified Staph aureus and some normal flora, some non-cryptococcus yeast, and other organisms. This patient was started on pip/tazo to treat the susceptible Staph aureus. I should mention that it came back susceptible, and was also prophylactically treated just by having HIV with CD4 count so low, presumably for a long time as well. So treated both for avium and for PJP prophylaxis. So the Unyvero, however, did identify pneumocystis at about 5 hours and also picked up a Staph aureus. So in this case, we're kind of thinking that maybe we're seeing higher sensitivity here, that this patient, pneumocystis would have been a good hypothesis as to why she was feeling ill. And in this case, they were already prophylactically treating it without any necessary laboratory evidence. So it's hard to tell. Well, this counted as a disagreement, a major disagreement in the comparative analysis. We're thinking that maybe we're actually detecting something that microscopy just couldn't, and really providing a basis for some of the therapies that we've already been starting empirically and prophylactically, that maybe we can now identify them from a molecular standpoint. Okay, here's our last case. So we have a 53-year-old guy who recently had a bilateral lung transplant, and he's presenting with some not very fun respiratory symptoms. While he was recovering from his lung transplants, he kept having some Pseudomonas tracheobronchitis infection, which turned out to be carbapenem sensitive every time that it came up. This was now several weeks ago and thought to have been resolved. The patient had been treated with inhaled colistin, and they kind of thought that they were over this. So they sent in this bronchoscopy with a BAL and looking to culture it, see what would grow. At this point, our standard of care was able to identify a Pseudomonas at 24 hours. At this point in time, they started treating him as if it were the original isolate, so using those carbapenem-sensitive characteristics. But then, unfortunately, carbapenem resistance was reported the next day. So here, the Unyvero was able to detect the Pseudomonas aeruginosa at 5 hours very quickly, but didn't detect any resistance markers. So this is kind of another tricky case where the Unyvero came in and was able to get us a pathogen identification much earlier. So we would have known that Pseudomonas was back. But one of the tricky things with organisms like Pseudomonas, of course, is that the lack of a resistance marker doesn't necessarily mean that there will be no resistance. And for this, we still need phenotypic follow-up. But in this particular case, at least we have sort of a day's head start. We know that the organism is there, and we can kind of treat aggressively, knowing that it's very possible that you can have resistance without the marker here. Okay, so just kind of in conclusion for this study, what we found, we think that really there's a lot of opportunity for implementing these rapid molecular diagnostic tests into respiratory algorithms. Of course, there's no substitute for phenotypic antimicrobial susceptibility testing, but just by having answers up to a day or more earlier, you can get faster identification of these pathogens, especially the well-known resistance mechanisms, we can have an idea of what drugs to escalate to begin with. It also can reduce the time that we can use to increase therapy or decrease therapy, kind of rein back some overzealous prescriptions and know when it's really needed to include tougher drugs. Also, compared to some of the technologies, either culture or microscopy, we think that there's improved sensitivity, and this for us is quite a benefit. Okay, and with that, I think we're done, so we'll turn it over to questions.
Thank you, Dr. Jeske and Dr. Bal, for your informative presentations. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. So let's get started. Our first question is for Dr. Jeske. Of the cases that you presented, by how many days faster or earlier did Unyvero detect a pathogen that culture confirmed in a subsequent sample?
Yes, thank you very much for that question. I think in general, the answer is 3 to 7 days earlier with Unyvero. In some cases where the results were 100% concordant, it was slightly shorter than that, but still at least 2 days earlier.
Great, thank you so much. And Dr. Bal, we'll go ahead and scooch on over to you. So the question for you is, what is your experience regarding Unyvero's detection of P. uroveci being pathogenic or due to colonization?
Oh, that's a great question. So we kind of talked a little bit about how there is colonization at play, but I didn't specifically address how this molecular technology did have that in mind when it was developed. So in general, when we think about the burden of pneumocystis, studies have found that probably the cutoff for being pneumonia causing versus just a colonizer is about 10 to the 5th copies per ml. So if it's below that, it might just be a colonizer, but if it's above that, it's likely to be playing a role in the pneumonia. And so the nice thing about the Unyvero here is that the analytical sensitivity was set to 10 to the 5th copies per mil to hopefully just pick up those cases which are true. Now, there's always a little bit of wiggle room in things like this, so there might be some edge cases, but we think that it's pretty in line with what we know about PJP colonization at this time.
Wonderful. Thank you so much, Dr. Bal. And so it looks like we have time for just about one more question, but I do want to remind our audience that any questions that we are unable to answer today and those that come in during the on-demand period will be answered by our speakers via the email address that you provided at the time of registration. So please don't hesitate to keep those questions coming in. So Dr. Jeske, we'll go ahead and end with you with this question. Some PCR pneumonia panels have semi-quantitative reporting capability. So what is your opinion about this?
This is a very typical discussion. I think in general it depends also largely on the sensitivity of the PCR and the level of detection of the PCR. And it seems, at least in the patient material that we investigated, there was a very good concordance between PCR and quantitative culture at the significance levels that are considered significant. So despite that one could fear that PCR would pick up very small amounts, it does seem as if the kit, without knowing specifically, is fairly adapted to the levels that you would typically regard as significant in culture. So I think in this data set we looked at, it would not have made a huge difference. But it depends. If it's an extremely sensitive PCR, it might make more difference.
Great. Thank you so much, Dr. Jeske. We want to thank again Dr. Jeske and Dr. Bell. Do you have any final comments for our audience? For our audience, Dr. Jeske, I'll go ahead and begin with you.
No, just that I would like to say we will definitely try to answer questions from the chat and whatever we were not able to address for time constraints here. So I'm more than willing to discuss more with anyone who might be interested after this seminar. And thanks to all who attended.
Thank you. And Dr. Bell, do you have any final closing comments for us?
Yep, just similar. Thank you all for attending, and please reach out if you have any questions we didn't get to. We'll try to get to them all. So thank you.
Great, thank you both. Before we go, I would like to thank the audience for joining us today and for their interesting questions. Like we mentioned, questions that we do not have time for today and those submitted during the on-demand period will be addressed by our speakers via the contact information that you provided at the time of registration. We would like to once again thank Dr. Jeske and Dr. Bell for their time today and their important research. We would also like to thank LabRoots and our sponsor, Opgen, for underwriting today's educational webcast. You can view the webinar on demand. LabRoots will alert you via email when it's available for replay. That's all for now. Thank you for joining us. Stay happy, stay safe, stay healthy. Until next time. Bye-bye, everyone.
Thank you.